Hi guys, so I thought I would do some sessions just looking at common skin disorders in the emergency department that you will encounter, but also that come up from time to time in the part 1 examination. And in this lecture we're going to look at blistering skin disorders. By the end of the lecture you'll be able to identify some of the more common and important blistering skin disorders and describe them in terms of pathophysiology, clinical presentation, treatment and prognosis. And critically, when shown a picture or a patient with a blistering skin disorder, you will be able to provide a rational differential diagnosis. So here's the first case, a 34-year-old female who presents with generalized blistering of the torso, face and limbs. This is just to get you thinking about your general approach to this problem, so you can pause the video and think about what further questions you would ask, what specifically you would look for on physical exam, and what your differential diagnosis might be. So pause the video and have a think. So when it comes to acute generalized blistering skin disorders, we can divide them into immune-mediated and infection-related, although the two categories tend to overlap quite a lot. As you can see, there are some common conditions here, such as herpes zoster or crusted scabies, or bullous impetigo. We will just go through a few of these conditions, but actually you need to know a little bit about each of these conditions for your exam. Let's start with some of the acute generalized immune reactions. And there's this complex of conditions that includes erythema multiforme, Stevens-Johnson syndrome, and toxic epidermal necrolysis. These are blistering skin disorders that are caused by type 4 hypersensitivity reactions and may be precipitated by viral and other infections such as Epstein-Barr, herpes simplex, some common bacterial infections, of course mycoplasma. Then certain drugs, particularly sulfur drugs such as cotrimoxazole, anticonvulsants and certain antibiotics. I just want to make you think a little bit about cotrimoxazole. So if you remember from some of our last lectures, this is a really important drug for drug reactions. It is associated as one of the commonest drugs that causes this complex, erythema multiforme Stevens-Johnson syndrome, hemolytic anemia, and aplastic anemia. Some malignancies may also cause erythema multiforme, such as certain solid tumors, but more so hematological tumors such as lymphomas and leukemias. So erythema multiforme often has a viral-like prodrome, which then progresses to a rash associated with target lesions, papules and macules, as well as blisters and bullae. The mucous membranes may be involved in erythema multiforme major, but it's mostly a skin problem. With Stevens-Johnson syndrome, the condition is much more widespread and involves to a much greater extent the mucous membranes, but involves less than 10% of the body surface area, whereas with toxic epidermal necrolysis, more than 30% of the body surface area is involved. Treatment is generally supportive. Remember, these patients would have lost a lot of fluid, are at risk of infection, and also would have things like electrolyte imbalance because of the fluid loss. Skin care is important, much as you would care for the skin of somebody with severe burns. And then there's a place for immune modulation, particularly the use of intravenous immunoglobulin, but also steroids and some immunosuppressants such as azathioprine or cyclophosphamide have been used. Pause the video and have a look at this picture. See if you can figure out what's going on here. So this is Staphylococcal scalded skin syndrome. It is characterized by widespread exfoliation and erythema with systemic symptoms in little children, things like fever or hypothermia, irritability. It tends to occur in younger children, and the pathophysiology is the production of exotoxins by Staph aureus. This is the reason why older people don't get it as much, because with older patients we tend to have developed antibodies to these exotoxins. However, it can be seen in immunocompromised patients or in older adults. What about this rash? I know it looks as if it's just on one side of the face, like a herpes zoster rash, and that might give you a clue as to what it is. However, this is a much more widespread rash over the entire body. Pause the video, see if you can think about what this is. This is something called eczema herpeticum. It's a vesiculopapular rash associated with systemic flu-like symptoms and sometimes prostration. It's really a superinfection of herpes simplex on another skin condition, particularly ectopic eczema. It occurs at the extremes of age and in the immunocompromised patients, and actually can be life-threatening. Treatment is generally supportive, and the use of systemic antiviral agents against the herpes simplex virus. This little child comes in 5 days after a viral type illness with persistent fever, this strawberry looking tongue and cracked lips, and this rash all over the body. Pause the video and see if you can guess what this is. Of course, this is Kawasaki disease. So just to remind you of the 5 diagnostic criteria that you look for: extremity changes, including redness, swelling and peeling of the skin of the fingers, a polymorphous rash over the torso and limbs. It can be maculopapular, but it can take on almost any appearance. There are oropharyngeal changes, the cracked lips, the red strawberry tongue, the pharyngitis. Then there's a non-exudative bilateral conjunctivitis and unilateral non-exudative lymphadenopathy. You need to have 3 out of 5 of these to be diagnosed with Kawasaki. Pathophysiology: it's a vasculitis of medium-sized vessels, and it's usually precipitated by infections such as viral illnesses, but can also be due to mycoplasma, certain bacterial infections, and specifically tick-borne or rickettsial diseases. The common cause in our country is viral illnesses such as parainfluenza or CMV, but remember, this can also be precipitated by COVID-19, just topical. Complications may be cardiovascular, such as pericarditis, myocardial infarction, aneurysms, or valve disease, or the effects of systemic aneurysms anywhere in the body, including the brain, so it can lead to strokes, the kidneys, or even the large vessels, and of course this may cause sudden death. And finally, this elderly gentleman who has had a stroke in the past presents with this crusting, blistering rash all over the body, but particularly in the buttocks and skin creases and in between the fingers. Pause the video, see if you can guess what this is. Yeah, so this is crusted scabies. It manifests as a widespread hyperkeratotic rash with vesicles, papules, and burrows, particularly in the skin creases and in the hands and feet and groin. It's really a hyperinfestation with the Sarcoptes scabiei parasite, and immune compromise, elderly, immobile, or patients with neurological conditions are at risk. It can be complicated by bacterial superinfection, fluid loss, or skin hypersensitivity reactions either to the infective agent or to the treatment. Remember, in children, the superinfection can lead to acute glomerulonephritis. So those were the acute blistering skin conditions. I put this slide up just to remind you that there are chronic blistering skin conditions that you may see in the emergency department as well, such as pemphigus vulgaris, bullous pemphigoid, epidermolysis bullosa, dermatitis herpetiformis, which is different from eczema herpeticum, bullous SLE, or drug-induced pemphigus. I will see if I can find an article online to share with you about the chronic blistering skin conditions. So that's the end of this short talk. If you have any comments or questions, you can bring it up in class. I hope you found this useful. Thank you.